Um, you may or may not know there are a variety, and I've just got this up here to remind you that there's this variety of nicotine products people are now using today. If you haven't heard of this before, I'd be really interested to know. But there are people who don't do any of it. There are people who do some of it, some of the time. They may smoke, they may vape, they may smoke and vape. That's called dual use, and it's very common. And if you sometimes ask people, do they smoke? They say no, but you must always ask if they vape. They may say yes. They don't see them as the same thing at all. So you really need to dig deep into nicotine use. And then you've got this newer, I guess, in interactions with nicotine, like the hubble bubble, or if you know what that is, the shisha, hubble bubble, argila. These are the water pipes that contain that you burn, as you do, burn tobacco in this water pipe, which is not safe, and nobody really, we assume that these are the water filters out things it doesn't. I'll come back to that later if you like. There's now the oral snuff called snus, and if you haven't ever heard of that, pay attention to that, particularly in young people quitting vaping, going on to a product. The manufacturer's name is Zyn. Snus is the term. It's a little um, Panadol-sized tea bag that you actually have. It contains tobacco, pulverized tobacco, oral snuff. So watch this space. It's growing in young Australians today who have gone from vaping to using these things. And watch this space for a flavored nicotine gum. Now, this is not like your prescribed or previously prescribed nicotine gum. This is nicotine gum flavored with strawberry, pineapple, whatever. And it's the attempt is to go around the laws and regulations in Australia today. So keep your eye on all these products because you never know what your patients or clients or consumers are using. So obviously, nicotine is classed as a poison under the Poisons Act in Australia. It's obviously the main psychoactive ingredient in tobacco. I might want to just correct Monica in one thing, Monica. I'm a physiologist, not a psychologist. Hence, I've got a handle on the physiology
So
of this.
sorry.
It's all right. I'll come back
I
to why
misleaded.
it helped me in my career to be a physiologist, respiratory, cardiovascular. So that really got me into this topic in the first place, the
So
whole
sorry for that.
cardiovascular, respiratory, physiology. But I just wanted to say that the main psychoactive ingredient in tobacco is nicotine, but it is not the sole one. Come back to that. It nicotine effectively has to come from the plant, but it is now made synthetically. But it is expensive, and there are some entrepreneurial vape producers who are saying, "Oh, we don't deal with the tobacco industry now at all. We're tobacco free. We have synthetic nicotine, which is what greener and safer." Not true. Certainly not safer, and I'll come back to that. But just thought I'd point that part out. Um, and obviously, internationally, and where our vapes come from in Australia today, the legal and illegal, all of it comes from China. And I just wanted to point that out in particular. The material that's in cigarettes today, what you're importing, obviously comes from the tobacco industry. They grow tobacco for combustible use and non-combustible, they extract it from the plant. Something you may not know, some of you may know, that it's illegal to grow tobacco in Australia. It has been for 2 decades, nearly 2 decades. So if you see a crop of tobacco, which I doubt you have seen, it looks like spinach, so you wouldn't necessarily recognize it. It's illegal to grow tobacco, even your own pot, your own plants. Illegal to grow tobacco in this country. Though we have native tobacco plants, some of you might know of Pituri, that's one of them. Minkalpa is another term for them. 25 native Australian plants that contain high doses of nicotine, as yet to be really exploited. And I'll come back to that too. So, how do you get nicotine into your body? You obviously inhale it, and that's been really important for those who use it because they've learnt over time that that's the best way to get nicotine into your bloodstream. Um, injecting it, ingesting it is out of the question. There's no, unfortunately, or fortunately, you'll notice there's no nicotine tablet we take. You chew it, it's oral, up your nose, in your mouth, oral mucosa, up your nose, into your lungs. This is all the respiratory tract. I'm pointing out my own respiratory tract. In your ears, part of the respiratory tract, but not in your gut. So we don't really absorb nicotine very well at all through the gut. So can you overdose by swigging a whole lot of nicotine out of say, a bottle, or chewing too much nicotine gum and swallowing the whole lot in one shot, the whole lot? No, you can't. It'll pass through. It's very hard to absorb nicotine through the gut. I'm just telling you that. So oral overdose by ingestion is really not likely to happen to any adult. It may occur, as in some toxicity occur, to a very small individual, a baby, small body surface area, small weight, with a gut absorption possibly could be fatal. We don't see it at all in Australia. We've never had really a case of nicotine, death by nicotine, mortality. So I just want to debunk that myth. The speed of delivery through into the lung is really an essential part of the reward from nicotine, speed. So inhaling nicotine gets into the arterial blood just like that. Literally just like that. And the technology they're using now to develop vapes in particular makes it even faster. So does speed matter? Yes, it does. The faster it goes into your lungs, the transition from your alveolar space into your arterial blood, remember you're bypassing the whole venous system, makes it incredibly, exquisitely quickly delivered. And that's our problem. I'll just quickly tell you right now, there's a hierarchy of nicotine delivery. Right up the top are vapes, and right at the bottom in speed of delivery are patches. So we do not have not one single patch addict on the planet. Why not? And I know the literature. Why not? It's because it's just so slow. A, the dose is incredibly slow, and B, the dose is very low. So I'll come back to that. Don't be afraid of overdose of nicotine. It really isn't going to happen. I'll just move on to the next slide. So who's still smoking or vaping in Australia today? You'll notice that people who are evidently highly dependent, and we're going to talk about who they might be later on and how to assess that. People with mental health comorbidities, comorbid drug and alcohol, perhaps that's all in the one basket often. Mental health and drug and alcohol comorbidities, high prevalences of smoking and or vaping. Remember, I'm always saying and or. People with diseases related to their smoking, why would they do that? That's what addicts do. They do it in the face of what they know to be contrary to their best interests. If you have a disease like COPD and you still smoke, I'm going to show you that later, that defines you as an addict. The fact that you do it in the face of what you know, and they do know, that it's no good for them. They've had a cardiac arrest. They've had vascular disease. They've had COPD. They may have had cancers, whatever. If they still do it, their diseases are related to their smoking. Unfortunately, that defines them as being addicted. Often also they've had multiple attempts to quit. So it's not as if these people are not motivated. We've been having a whole big review about motivation. Most smokers want to quit. Only about 3% actually achieve that. 97% of people have a real difficult time of it. Is the target today in Australia getting harder? I believe it is. That is harder to treat. Are we left because of our prevalence of smoking? As you know, lucky for us, prevalence of smoking has gone right down for a whole gamut of reasons, but one of them is because of pricing and because of our campaigns, our big national and statewide anti-smoking campaigns have been hugely successful. So lots of people have quit, and then are we left with those who can't do that? Could those who could have quit have quit, and we're left with those who couldn't, I believe. Now, multiple life stresses is part and parcel, unfortunately, of the above, right? The group of people who find it very difficult are more anxious, more distressed, and often in a lower socioeconomic group. That's something that people have in common, but it's not exclusive. And we'll talk about vaping. It's not exclusively low socioeconomic status at all, but in smoking it practically is. And as unfortunately, our Aboriginal and Torres Strait Islander populations in Australia are somewhat behind in the progress we've had with reducing smoking, and unfortunately some taking up vaping as it moves into those groups, and in Indigenous pregnant women. So we're going to talk a little bit about all of these groups of people. I believe some have much easier facility, that is capacities to quit, and others have a lot less. So some more basics about nicotine. Nicotine is colorless and odorless. Colorless. It's not yellow. I put it there, yellow, but it's not yellow that stains your fingers or your white hair. It is the tar that's burnt, and any green leaf will go yellow and stain. So nicotine is colorless and odorless. Why does that matter? Because if you happen to be a passive vapor or a passive smoker, you're not going to be able to smell nicotine. You can't smell it. So even if people say, "Oh, look, I can smell the passive vaping pineapple flavoring. Isn't that yummy?" I'm going, "Yes, but there's nicotine in it." "Oh, but I can't smell the nicotine." That's right. You cannot smell nicotine. Now, I wanted to point something out to you, all of you, because we talk a lot about what is called the topography of, whoops, oh, sorry, I'll just go back to I'm just getting out my fake cigarette. I'm not sure if you can actually see it. Monica, can you see my cigarette on the screen? Because I use
I can.
it. So just to point out, I've got, and I'm not sure if you can see my little arrow here. Can you see my arrow?
Yes.
Oh, excellent. Thank you. I want to remind everybody that when you smoke or vape, I might add, same thing. Here's my vape, my purple vape. You can see that. If I drag a big cigarette, a puff from my vape, or I drag a big puff from my cigarette, this is not a real one, 80% goes out into the air, 20% into me. So the very first myth about smoking is that you get all the content of whatever it is. You don't get all of it. 80% is in fact out into your environment. Could be a small space, could be a very large space, could be a big hall, could be a car. So keep those environments in mind when people are smoking or vaping, that they're subject to passive smoking, we all know about, but passive vaping equally. So they're getting nicotine in confined spaces too. 80% of what the person has just exhaled. Remember that. So I've mentioned about the respiratory tract and how quick that happens, and how you don't eat it or absorb it through the gut at all. But the main feature for me is that nicotine is a very short acting drug. It's one of the shortest ones humans use. We excrete it very quickly. That's called the nicotine metabolism of how you excrete it. But what's important for you to know is that nicotine lasts about 2 hours maximum. Its half-life is 2 hours. It's got a whole life of about a day, roughly, but a half-life of about 40 minutes to 2 hours, which means that once it starts to decay very quickly, and how you metabolize that matters, how quick that decay is, you will actually start needing to do it again. So just keep in mind, if it's very short, you're going to have to do it often. It wears off incredibly quickly. This is why, and you can tell your patients this, cigarettes are packaged 25 in a box because that's the half-life of nicotine divided up by your waking day. So the penny drops for a lot of smokers, just informing them of that. 25 in a packet, my waking day, you need a dose about every 40 minutes, about every half-life of nicotine, which is really shocking to them. They really start to feel hugely manipulated. And we're telling kids the same thing. But remember that 2 hours is a long time in the life of a smoker or a vapor today. 2 hours is a really long time. You metabolize nicotine to cotinine. I'm going to talk about that a little bit later on. And that the nicotine contents in your body when you smoke a 1 milligram, say, cigarette, like a Marlboro Red, strong cigarette, you might inhale that. Plasma levels, however, are never in milligrams. You never get those doses. These are fatal doses. Most of it, remember, is out in the air, and it's diluted hugely by your blood volume, and your lung volume. So what you end up with is nicotine in nanograms. And if you care to look, which not a lot of people do, into the patient information or the PIs in say nicotine replacement therapies, they're all in nanograms, not in milligrams. Check it out. And a lot of people don't. And that's been the bane of my life, is to remind people you never get 21 milligrams of nicotine over the 24 hours of a patch. That would be a fatal dose immediately. The levels are in nanograms. Please be aware. So more of the debunking of myths, which is our job. We would never recommend, and that's just been reiterated in another big paper about this, cutting down or smoking less. Unless you happen to be using NRT, nicotine replacement therapy, at the same time, like having a gum and then a cigarette, or wearing a patch and smoking. Can you do that? Yes, you can. Or vaping? Yes, you can. Is it safe? Yes, it is. I'm just pointing out, otherwise, cutting down and smoking less is not safer. What happens is people change the manner in which they smoke. They drag harder, they inhale deeper, they change what's called the topography of their smoking. And unfortunately, it's not only not better for you, it's worse for you. I'll mention that again later on. Just to reiterate, don't recommend cutting down unless you're using something, and it could be varenicline, but don't recommend cutting down on its own or smoking a weaker dose of something. Milder cigarettes, you all remember, are not safer. Rolling your owns, for reasons where people think whatever they're rolling, and remember that might be chop, illegal tobacco, which is prone to moulding. That's another story I don't have time for today, so they inhale the mold. But rolling your own cigarettes is not safer. They are smaller, yes, they let a lot of air in. Again, dragging harder, having to compensate for the fact that they're diluting it by having to drag harder. So roll your owns are not safer. All medications for smoking cessation are safe. There's this myth going around about a lot of pharmacotherapies, none of which is true, and I'll come back, particularly, I guess, and I want to declare I have no conflicts of interest, not with pharmaceutical companies that make medications for smoking cessation. Obviously, I don't work for the tobacco industry either. I have that up front on my slides. What about vaping? What about harm reduction? Is it safe? It may be safe, but is it safer? We've yet to see, and I'll talk about that again later. The topography of smoking and vaping. I talked about deep inhalations. People, they say, look, I smoke 25 a day of these, right? Most of it's in the air or the ashtray. Or I could smoke 5 a day and get from 5 what I get out of 25. Be aware how you smoke matters. And it's difficult to know because they hold their breath. They might use some of it, I said, or all of it. The nicotine concentration might be low and they compensate. They smoke fewer, they compensate, and smokers titrate their plasma levels of nicotine to the nanogram. They're incredibly accurate. If it's too strong, they'll smoke it less. If it's too weak, they'll smoke it more or more of them. They can tell you that. Now, they don't know about the nanograms, but they certainly know, oh, it's too weak, oh, it's too strong, or whatever. They'll know exactly what they like. And what are we talking about with what they like? That's nicotine in the brain, which is the target organ here. It's nicotine in the brain. That's the target organ. Here's the brain. Here's a nice sort of schematic description of where nicotine acts, and the acetylcholine receptors where it acts mainly, not entirely and only, but just to demonstrate, this is the old primitive part of the brain, the reward pathways, the mesolimbic system is very primitive in humans, as you know, and so there is little autonomy is the word for this, over or control over the need to put nicotine in these nicotine acetylcholine receptors. And we have them because nicotine crosses the blood-brain barrier, and reminding you that not all drugs do. Um, it's there to prevent large molecules crossing into the brain, and there's a potential now to make a vaccine, I'm just pointing this out, to prevent nicotine crossing into the brain. And that's another story some other time. So nicotine acts on those acetylcholine receptors that I just showed you in that area in the mesolimbic system in the brain, and it does usurp takes over acetylcholine, which is the natural ligand. That's why they're called nicotine or nicotinic acetylcholine receptors, because they really are normally acetylcholine that's there. And there are hugely different and variable types of these receptors. I will attempt to come back to that later on. But I want you to be aware that there is heritability in these receptor types. Why I'm talking about that is because nicotine addiction is a highly heritable trait. Not everybody who ever smoked in the history of trying it out, and my hands up, I did when I was 17, doesn't mean that you become addicted to it. Unfortunately, there are susceptible people who are highly susceptible to nicotine addiction. Those responses in the brain, those acetylcholine receptor responses in those areas in the brain, and unfortunately, you don't have much control over that. So this is important to tell A, families of smokers, and B, a smoker and their children, to say, look, you weren't born to smoke, but you might be born with a specific response to nicotine that not everybody has. And that's really important to pass on to your patients, but also for yourself to be aware. That's why you get some people who have never had any problems with nicotine, and some who have huge problems with it. And exposure to nicotine in the developing brain, need I tell you, has lasting changes in the brain's function, nicotine acetyl receptors, and I'm going to talk about how detrimental this is in mental health. I mentioned a little bit about heritability and how can we tell responses. We've seen it in genes, and there are enough studies now to show this. And it's more heritable than alcohol dependence. If you've got the picture and you know in your mind about alcohol dependence is a highly heritable trait, this is more so. More so. Keep that in mind. We can test for this. We can test actually genes. We don't have to do that because we've got a questionnaire called the Fagerstrom Dependency Questionnaire, which some of you might know. One of the most important questions you ask is how soon after waking do you need to do this? Within half an hour is an indicator of these genetic comorbidities. The genetic effects are result in the need to do this really on waking, as in once you start to neurotransmit and you're awake, you'll need to do it. There's other things that are really impressive to remember, because responses to pharmacotherapies for smokers is also a heritable trait. Some people do very well on, say, varenicline or Champix, right, or bupropion, which is Zyban, or NRTs, and some don't. You have to check around, look around, change treatments. Don't blame the patient. Don't blame the patient for not being motivated. Don't go there with lack of motivation. I want to remind you, nicotine is not benign. It is unsafe, I think, in mental health concerns. I work a lot at the moment in mental health and smoking and vaping. And in that space, we see people quit and their mental health is so much more improved, so improved if they quit self-medicating with nicotine. And what are they self-medicating? They're self-medicating what they perception of this is what's called the stress paradox, which you may have heard of, meaning I'm feeling very anxious, in inverted commas, nicotine is wearing off. I'm feeling distressed, I'm upset, I vape or I smoke, and I feel instantly, remember, going through the lungs, instantly better. See, smoking makes me feel better. And then, of course, it wears off. It's got this incredibly short half-life. And that is called the stress paradox, I'm afraid. That's a little bit more about the stress paradox. And there's no evidence, any benefit of nicotine in controlling or managing the distress itself. It's the pharmacokinetic effect of nicotine in the brain and then it wearing off, which is really exacerbating this stress in the first place. Which is very distressing for us to know. But do you explain that to your patient? I do, right? So, as I said, there's nicotine in the brain. There's two organs really hugely important in smoking and vaping today, and that's the liver. So, the brain and the liver. And the liver has these two main roles. One's role is to eliminate nicotine, genetically determined, and the other is enzymes that are stimulated by smoke, and some of you probably know that, and its effects on other drugs. You probably know that, I suspect. So the first part of excreting nicotine, which is genetically determined, and there are racial variations of this, liver enzyme CYP2A6. Remember, there are about 2,000 liver enzymes which take care of nicotine. It's not exclusive to nicotine, but there are ranges of 2A6. So you have type 1, 2A6 type 1 to about 12, and we know that now today. And if you happen to be, bad luck for you, a fast metabolizer of nicotine, this is in your liver over which you have no control, right? You need to smoke or vape more. And if you smoke or vape more, you're more addicted to it. And if you smoke or vape more, you're going to get the medical consequences of this. So fast metabolizers are at risk, and this is well documented. We have all the citations you can want on these things. Fast metabolizers are at risk of lung cancer because they simply have to do a lot of it to maintain their plasma nicotine levels. We don't know much yet about vaping and cancers, but we certainly know that fast metabolizers are at higher risk of COPD because they've got to do a lot of it. And the slow metabolizers do better on one form of NRT. So if you've got a client or a patient who's used one patch and was brilliant, fantastic, that tells you, and it certainly tells me, they're slow metabolizers of nicotine. If you have a patient who says, I'm wearing a nicotine patch and I'm still smoking and it hasn't touched the sides, then I know that they're fast excretors of nicotine. That tells it to me. And the fast inhale deeper and they have higher expired carbon monoxide readings. And I test that in my biomarkers all the time. Another hugely important and critical liver enzyme effect is what you possibly do know about when it affects antipsychotics in particular. You've probably heard that if you smoke, you need higher levels of antipsychotics. You may not know that you need also mostly higher levels of anticoagulants. I'm not sure, but the antipsychotics, the clozapine effect, the olanzapine effects, some of you might know this. It's when you smoke, as in you're combusting, you produce this other chemical, you produce carbon monoxide because you're combusting. This is smoking anything. And by the way, shisha, hubble bubble, it's the same. You're combusting. Whatever you combust, marijuana, etc., you're going to produce PAHs, these polycyclic aromatic, which then do this induction trick in the liver, in liver enzymes, which induce 1A2 and 2D6. These are important enzymes in pharmacotherapies and in metabolizing caffeine, 1A2. And what happens with caffeine is really important. And I want to remind you and do this because you'll see when we do an assessment of a smoker, we always remember it's a smoker. I always ask them how much caffeine do they use, and they'll tell you, oh, decaf. Yeah, okay, good. Or Diet Coke. How much do you use? Well, liters, liters and liters. You ask your smokers how much caffeine do they use, and you'll probably be hugely surprised. It's certainly double, treble what other people might be using. And what happens, you might know about that with the clozapine effect, if you quit smoking or go to vaping where you're not producing these PAHs. Remember, from smoking to vaping changes your antipsychotics. From smoking to vaping changes your anticoagulants. Warfarin classically, right, is affected. So unexplained bleeding, you're raising plasma levels of antipsychotics, painkillers, insulin, caffeine, alcohol. If you stop smoking, use NRTs, or go to vaping. So I just want to make you aware of that. These things matter a great deal. And remember, this is not a nicotine effect. So you're not going to change anything by giving smokers more NRT. You have to change the doses of these pharmacotherapies and caffeines and alcohol. We have this, and I'm not sure, Andrew, you can possibly mention this. I'm sure you do. We have it in New South Wales Health. I know it very well because I wrote it. These are these drug interactions that are important, and you can see triple stars for clozapine, which you know about, caffeine and alcohol, which you know about. You may not know about heparin, and at the bottom is a newer one we've added, and that's methadone. Methadone toxicity in people who quit smoking or go to vaping. Pointing that out. The next thing I wanted to mention a little bit about it is nicotine withdrawals, which we have well described years ago. And why I've got this up here is I want to remind you that nicotine is such a short-acting drug. The ones in red are what happens to people from one puff of a vape to the next. And this includes kids. I'll show you in a minute. They get urges to use it. They become anxious, aggressive. Remember, aggression is a significant symptom of withdrawal, well documented. They get hungry. They can't concentrate. They become dysphoric. Later on, may become depressed, can't sleep, or become tired, develop mouth ulcers, if you haven't heard about that. 1 in 3 smokers who quits develop mouth ulcers or aphthous stomatitis. I want to point that out. It's not always volunteered. People don't even know there's a relationship between their quitting and their mouth ulcers. Some do. That's how we learnt about it in the first place. And I did quite a lot, a big project on that some years ago. Constipation is something else. Some smokers know I need to sit on the toilet, move my bowels with a cigarette or now a vape, and it is nicotine that's doing this. So I wanted to point out you can have this between cigarette smokes, the ones in red, and the other ones are a bit later, a day later or a little bit later. But I want to remind you that withdrawals last for weeks, not always days, but they certainly, with the intensity of it and the frequency, they actually go down. So it's less intense and less often. This is getting no help, right? This is what happens to people in some cases who have no help. And I've got there 62% of smokers relapse due to withdrawals within the first 2 weeks of a quit attempt. So if you're going to help smokers do something, you've got to help them within the first, or vapers, the first 2 weeks are really seminal targets. And I just wanted to add that nicotine toxicity and overdose is extremely rare, but we are seeing it increasingly in adolescents because they're getting huge doses of nicotine, and we're seeing syncopes and seizures. Watch this space for seizures. Have you had anybody take a vape, take a big breath in? We've seen it in kids and just fall down with seizures from vaping. That is within the time span. kids with no history of seizures, no inheritable trait of seizures. Shocking outcomes. So just a little bit
Sorry,
about, yes.
there's a question in Q&A asking, just wondering why all people on antipsychotics smoke constantly as if they are so addictive to it. So would you like to
Yes.
say something on
Well,
this?
they are absolutely addicted to it, and because if they're on clozapine and they have to smoke more to get an effect, which is a bit of an irony of their clozapine. It sounds a bit strange, but their plasma levels we know could be 3 times higher in psychiatric patients, particularly, say, in schizophrenia, which I've worked with a great deal, 3 times higher plasma levels of nicotine. Why do they have such enormous amounts of nicotine required in their mental health? We think, and this is becoming evident, that there's upregulation, that is more production of nicotine acetylcholine receptors in these cases in mental health. And this may have started very young, very, very young. That is, we know that there is a relationship between smoking in pregnancy and a child of that mother who smoked in pregnancy becoming heavily addicted and have mental health concerns right through its junior years and right into its adulthood. There is even a very strong relationship between smoking in pregnancy and in the mother, and schizophrenia and suicide in the child of that mother. So strong relationships. Nicotine is truly poisonous to the developing brain. And most of our young mental health patients started doing this very young. This is a little bit, I'll come back to that. We'll talk more if I have time
There's
about
another
that.
question, sorry. There's
Um,
another question in chat. Does stopping smoking lead to weight gain?
I will talk about weight gain, no, and there'll be, well, the weight gain concern is important. Can we leave that till later, and we'll do that in the discussion, and remind me somebody to talk about weight gain, because I did a big paper on that, because we were very interested in what happens with weight gain.
Sure, no
So
problem. Yeah.
hang in there. So this is a little bit about adolescents and signs of addiction in adolescents. They're irritable, so never underestimate a young person's symptoms of withdrawal. I have seen in my career no more serious cases of nicotine addiction than I'm currently seeing in young adolescents. It's not that I've never seen it before in smoking adolescents, but now in young adolescents, they are so symptomatic. It's hideous. It's dreadful for them. It's not well understood by the family and, of course, by the school. But you can assess for this. One of the things we've been looking at, signs of addiction in young people, is that they can't stop. The latency between doing it gets shorter and shorter. They started doing it and they had no intention of doing this relentlessly, and now they are, and they do it at home alone. Now, adults smoke at home alone and adults vape at home alone. But if you think home alone in an adolescent, you're thinking, where's the peer group pressure? There's none. They're doing it because they have to do it, not because they choose to do it. So think home alone. It's a question we always ask. This is about quitting. I told you a little bit about these timelines when you attempt to quit. This is spontaneous quick. This is an oldie but a goodie. When everybody decides they're never going to smoke ever again, by the end of 2 weeks, most people have gone back to doing it. And we can see actually there are timelines. This is relapsing, spontaneous quitting without any help. Unfortunately, by the end of a year, maybe today in Australia, we know about 3% of people are still not smoking. And this is why I'm saying the first 2 weeks, if you help somebody stop smoking, if you want to help them, don't say, I'll see you in 2 weeks, I'll see you next month. You've got to see them within the week, because in 1 week, you're going to lose 50% of them already. Even if you're giving them pharmacotherapy, whatever you're doing, follow up at least a week. And these are our goals. This is taught us to talk about timelines, like the risk of relapse the first 2 weeks is the highest. You saw that. The first month is high, but it gets lower and lower as time passes. So the risk of relapse a year into it is minimal. It all happens right in the beginning, and that's the point of me pointing out in the slides. If you're going to see somebody, see them often. You don't have to see them a lot all the time. It's just the first month, the risk of relapsing is pretty high. So follow-up is so important in this. I wanted to quickly talk about nicotine overdose and toxicity. As I said, look, we rarely, if ever, see this extremely rare nausea. Me, Renee, Bittoun, who doesn't smoke or vape, doesn't use nicotine. I'm naive to nicotine. I'm naive to nicotine, as many of you would be, I suspect. If I wore a patch, it would make me feel pretty yuck. 121. It's not because I'm overdosing. It's because I'm naive to nicotine. I have no tolerance to it. And maybe if I put a patch on again tomorrow, I probably feel a lot less yuck. You develop tolerance. It's like smoking. You see them sometimes get a head spin. That's the term. They smoke a cigarette or they're head spinning the first one in the morning because nicotine has worn off overnight. It's in their bladder. They're excreting it. Oh, head spin. The next one they have, it's gone. You develop tolerance to it really quickly, but also you lose it overnight, which is very interesting in itself.
Do you want to take a break for 5
can you give
minutes?
me 2 minutes?
Yeah, sure.
Can you just smoking about the medical consequences? I quickly want to remind you that it affects every organ and system in the body. And I had to remind a medical person just recently, nicotine goes everywhere. It's in your plasma. It's floating around to absolutely every cell in your body. And as we learn more and more, we're looking at the effects of, say, recently a paper on uveitis, and vaping in particular, very concerning. Risk of seizures in smokers and in vapers in particular. Cancers, obviously, immunology. I want you to remind you the dentists are very worried about smoking, of course, and now vaping due to not just the flavorings, but due to the effects of these high concentrations of nicotine in the mouth. So we can now have a break. It's 20 past, and we'll come back to assessing a smoker and a vapor, and then how we manage it.
Thank you, Renee. Should we talk about it towards the end?
I think we'll give people their break, and then if there's an opportunity towards the end, it'd be great to talk through.
Sure, no problems.
And Renee, you deserve a break too, or at least a tea or coffee or something.
No, I'm on a roll, as they say.
All set.
I hope this is covering things that you.
No, it's wonderful to hear from the physiology perspective and all those insights that you're providing. It's great. Thank you.
I just have still quite a lot to cover. I'd rather not have questions.
Yes, we will edit it. When we'll post it,
I see, right. Yeah. I'm happy to continue on now.
Yeah, I think
5 minutes.
Yeah. Yes.
Yeah. Okay. Well, thank you for coming back. Hopefully, as you can see, I'm a bit on a roll, and I'd rather, if we have some questions, we'll leave it to the end so that we can have a bit more time for that. So, material about how we go about assessing a smoker and a vapor. As I mentioned before, there are people, of course, who do both, of course. And you can see there's comorbid substance use, of course, in a lot of this. Not always, but often. I don't need to tell you how to suck eggs, how to talk to smokers and vapors. It's exactly the same. I like to talk to them about the biology of this because it's an eye-opener to them, explaining how, say, the liver works, the heritability of this. I think this is often a real eye-opener to many people, particularly those who've always found it difficult to quit and can't understand why they've been able to do everything else in their lives but not this, and compare themselves to other people, which is often a big mistake to do, because this is definitely not a one size fits all at all. So we don't talk about failing. Again, I don't need to tell you how to suck eggs, but explain that this behavior of smoking and nicotine in the brain, and how you're there to help manage this better. I like to use the word managing. It's better than saying you need to quit on Monday. If my view is, if they could have quit, they would have quit. So let's see how we can manage this better, rather than, and I say that to smokers, I say that to vapers and kids as well who vape, rather than saying you've got to quit, you've got to stop, whatever. Take the pressure off by saying managing it. And as I said, the treatments regimens are certainly not a one size fits all. So we talk about, strong dependence. These are physical addictions to nicotine. This is not a lifestyle choice. People are not choosing to do this at all. They do have this conflicting drivers of enjoying it and needing to do it, and have a poor understanding. Many do, some do, but many don't, especially not young people, confusing the enjoyment with the need to do it. And I talked about doing it at home alone in kids who need to do it rather than choose to do that. Fear of failure and poor self-efficacy. I mentioned about comorbid other substance use and misuse. These are barriers. If you're going to respond by drinking or other substances, is that helpful? Not at all. One of the major barriers we know is whether you live with a smoker or have most of your friends smoke or vape today, right? So the principle is the same. So your environment around you is a positive thing. People do it all the time. And unfortunately, if they're doing it around you all the time, not only are you subject to their passive vaping, passive smoking, you're not just breathing it in, you're breathing in their nicotine. Think that, but you're also seeing them do it. So it's part of the memory circuitry to do with reward pathways. And this is unfortunately stimuli to do it. If you nag a patient, and we've known this about smoking in particular, if you nag enough, they'll go somewhere else. So don't nag. If family nags, you'll often see a client rolling their eyes and going down to the shed to have a cigarette because they're over being nagged about it by family and friends. So we try to debunk this urgency, this of having to do it immediately, by saying, let's manage this better. That's my language anyway. And I want to remind you that impaired decision making is a hallmark of addictions. On the one hand, I shouldn't do this anymore. By definition, right? If you do it in the face of what you know to be contrary to your best interest, that unfortunately marks you as being addicted to it. And that impaired decision making, that is, I can't reconcile what I have to do with what I want to do and what I need to do. That reconciling is very difficult for addicts of all substances, I might add. How do we assess a smoker or a vapor? We do the 5 A's. We ask, we assess, we advise, we assist, and we arrange follow-up, which I mentioned before. Asking about what is the product that you're using. Remember, there are multiples of them. We ask about, by assessment, we ask about the time to first cigarette and now time to first vape. We ask about their previous quitting history. This tells me a lot. I mentioned that earlier. If you smoke while you're wearing a patch, that's a giveaway to me. That's a flag that says, oh, we're not giving them enough NRT. Simple. Not that they were weak or that they were not committed. They were doing it, but we weren't giving them enough. So these pharmacological failures, like they've tried varenicline and it didn't work. Well, in 1 in 3 people, 1 in 3, it doesn't work. So, yeah, it could be you. Bad luck. Move on. Don't blame the patient for not being motivated. Talk about family history and ask about that, and talk about heritability and explain it. And remember, always ask about their environmental context. Where are they doing it? Who's doing it? Is it in the home? What are your rules and regulations about smoking indoors and outdoors? and consider their psychiatric comorbidities, fast metabolizers, slow metabolizers, other medications, and caffeine and alcohol use, and the fact that they do it daily. So that's the sort of thing we're doing today. We can class, and we do, nicotine addiction. Just think like drinking versus alcoholism. Some people are social users of it, and some people are evidently alcohol dependent. There's a whole range of it. There's a range of this in nicotine addiction. There's the mild, the moderate, and the severe. So your social smokers who may not do it every day, or the social vapers now who just do it on Friday night or whenever they're socializing, may not need medications. There's the ones who do it every day, but wake up and it's not number one thing they have to do. 1 hour after waking may need medications. Some do, some don't. We give them a starter to see how it goes. And the ones who do it within minutes of waking up, do it in the face of the medical consequences, have many attempts, and it runs in their family. These people need quite extensive pharmacotherapy, for sure. And what might that be? This is, again, a bit more about the same. I've just wanted to say that what I do have here about starting young, we certainly know the younger you started, the more dependent you are. If you started very young, and I always ask not why you started when you were young, but how old were you? Because this developing brain, if you started at 10 or 12, and remember there are kids now who are vaping in final year of primary school, meaning they could be 10 or 11, not uncommon. By the time they're in high school, they've started very young. The brain is developing around nicotine, which is serious. And the younger you started, the harder it is to quit. So the 60-year-old who started at 10 has just as much difficulty as the 15-year-old who started at 10. I'm just pointing out, the younger, the more neuro-adapted you are to nicotine, which is really a big concern with young vapers for us today. And I wanted to just talk about, obviously motivation. It's not essential. I don't think it is, and it's increasingly showing that it's less and less essential. That is, you don't have to be 100% determined you're going to quit. We can help you manage this better and get them on the pathway. And I use biomarkers all the time. I didn't talk about ethnicity, but I did talk about metabolizing nicotine. Just for those who work with clients around who are from the whole of the Mediterranean Rim, have been well studied, possibly the Turks the best. If you come from the Mediterranean, we're talking southern Spain, the Mediterranean Rim are fast metabolizers of nicotine. Southern Spain, southern France, southern Greece, Turkey, the Middle East, North Africa, all that area. If you know of your smokers and you think this is true, are they big smokers? Do they metabolize nicotine very quickly? Yes, they do. They're big smokers. They use a lot, and they have high prevalences of lung cancers. I'm just pointing this out. So ethnicity matters, and they're going to need more pharmacotherapy. We use biomarkers, I do all the time, to validate self-report. That is not just saying, are you smoking? Are you vaping? And just expect a no or a yes. I try to get an independent marker, and I think increasingly, certainly in hospitals, they're doing this now, just to be able to identify somebody's using nicotine. They might be doing some tests I'll show you in a second. The toxicants might be device specific. I measure nicotine metabolizing ratio all the time. I want to know if my patient's a fast metabolizer or not. That helps me nuance my pharmacotherapy. It enhances it because you get wonderful biofeedback from this. They love doing these tests and looking what the answers are. The dilemma we have with vaping is we can't use some of these biomarkers for vaping because we don't have a test for not vaping. If you're using NRT to help you not vape, it'll be positive. I'll come back to that in a minute. So we do breath expired carbon monoxide. remember, combusting any organic material. And if you're serious about this, I suggest you get some of this equipment. We look at reminding you that nicotine is very hard to test, by the way. Nobody really does nicotine itself. We do cotinine. Its metabolite lasts longer, it's more stable, and we can do it in urine, we can do it in saliva, and we can do it in hair. And I do it in saliva because it's non-invasive, and kids don't mind giving me a saliva sample. And I can do the metabolite of nicotine that way too. And that's why I say that when we can look at the metabolism of nicotine and just see how much pharmacotherapy you might need. This is what an expired CO monitor looks like. So blowing into that is easy, and we get normal values and we get high readings. And when you have a high carbon monoxide reading, the implication is carboxyhemoglobin. The normal value in Australia, we've done that many years ago, is 2.75 parts per million. And the highest reading I've ever had in a patient who only smoked 5 cigarettes a day, only, was 100 parts per million. He was taking everything he could possibly get out of those 5 a day, which means why this particular gentleman presented with unexplained pulmonary emboli. Why do you have pulmonary emboli? He had a high carbon monoxide reading. He had high carboxyhemoglobin, which made him make more hemoglobin because you hemoconcentrate. All smokers hemoconcentrate. They have higher hemoglobins than they would have if they were not smoking. Have a look at hemoglobin. It can be a marker for you. Just hemoglobin or hematocrit can be a marker for you if you have nothing else to test, that they've stopped smoking. And it takes about 3 months, as you know, the life cycle of the red cell. So we can do urine cotinine tests. This is done now, I understand, in many hospitals in Australia. Anaesthetists like doing that. They want to know, is my patient a vapor? They may or may not volunteer it. So you can test urine and you can test saliva. And this is a saliva test I use all the time. This is my desk, and this is the saliva test I use. And I've got my little type of saliva test in front of you. I'm not sure if you can see it. Doesn't really matter. It looks just like that. And you put this into your mouth and you chew on it, makes enough saliva to put into the test tube, and there's a reagent in the test tube, and that'll come up and give me accurate levels of nicotine or cotinine, its metabolite, on the actual test tube on the spot within 5 minutes of doing this. So my patient is with me there, and we do it, and kids like doing it, and people like doing it just to have a look at their changes in this, because it does change hugely. So this is what it ranges between 10 and 600 nanograms per mil in vapers, and this is a positive saliva cotinine test. And this is somebody who did this test for me, and I just to demonstrate why we do this. So basically, managing nicotine addiction, we take a patient's histories, we assess their addiction, we obviously implement a management plan, we start a pharmacotherapy if required, if needed. We give them behavioural advice and to modify their lifestyle factors and how we're going to do that. And we refer on. And we'll talk perhaps a little bit later with Andrew about how we refer them on. How do you refer patients on? To where? Just in terms of pharmacotherapies for smoking and for vaping cessation, we always want to, as best we can, do evidence-based interventions. And I'm saying as best we can because with vaping, the evidence is growing, but not substantial enough. So we play it by ear somewhat. But no evidence to support hypnotherapy, acupuncture, psychotherapy, negative affect counseling, self-help books, lots of sort of self-styled experts selling books. The evidence is really not there. There have been trials, by the way, placebo-controlled trials, double-blind trials in some of these things. If you can do it, you can't do it with hypnotherapy or acupuncture, but the trials that have been done, there's no evidence. And I talked about no evidence to cut down. So we are obliged to suggest to patients that we would not recommend hypnotherapy and acupuncture. They're the two most common questions. What we can recommend is pharmacotherapies of all types, combinations of all types, and we do combination treatments all the time. It came up recently that that in other countries in the world, they don't even know much about this. I think it's very interesting. I'm lucky enough to be invited to speak outside Australia quite a lot, and they don't know about combination treatments. In the States, some places they do, but in other countries, it never occurs to them that we might be underdosing with NRTs. But the evidence is there that you can do it. Just a lot of people don't read the evidence. What can I say? We can recommend anxiolytics like nortriptyline, naltrexone, though they're not registered for use as smoking cessation aids in Australia, nor are vapes, I might add. Please look at the TGA. You can hear me go. Effectiveness, combined use is more effective than a single use. So you want to be effective, give them some form of NRT or a couple of forms of it at the same time. And varenicline is by far and away the most effective of all pharmacotherapies for smoking cessation. Cytosine, if you haven't heard of this, is coming. In fact, it's available at the moment in very limited pharmacists. Cytosine is the original varenicline. Varenicline was derived from the plant called cytosine. This is taken as an oral tablet or a tea. Watch this space. You can possibly drink it. So the important issues in our pharmacotherapies for smokers and vapers that we have chronic underdosing of NRTs in patients. If a person is smoking and vaping and they're using and they're doing it all at the same time, and you're trying to give them NRT, you're not giving them enough if they still need to smoke. So you need to up the doses. So don't be shocked and horrified that we have two patches at a time, 3 patches at a time, 4 patches at the same time every day, 4 new ones. Don't be shocked and horrified. It's not uncommon, and I'll show you evidence for this. We've got evidence, publications for it around those who do this well in some of our colleagues outside Australia, and certainly inside Australia, we're doing this very, very well. There's no serious side, you can do multiple patches, no overdose. Longer you use the pharmacotherapy, better. There's evidence for that, for at least 6 months. So if you're going to be on a patch, 6 months of it. If you're going to be on varenicline, 6 months of it. Why do we go 6 months? You need to learn how to behave with that. You need to not be a responder to stressful events. So we like to use pharmacotherapies to keep people afloat, really. That's the bottom line. No serious side effects from varenicline, and most of the concerns were a nicotine withdrawal. So we combine varenicline and NRT all the time. I mentioned this earlier about the genetic variations in responses to therapies, and that's to do with receptor types or how you metabolize bupropion, for example, or you're slow metabolizer of nicotine, or you're a fast metabolizer of nicotine. This is a little bit more about NRT. Which type would you choose? My first choice is usually a patch, simply because compliance is better, right? It's much easier just to put on a patch and off you go. And my recommendations, if you put on a patch and off you go, it either replaces the nicotine, or if it doesn't, you need to smoke on top. And if you do, fine. No big deal. Do whatever you need. And if it's not enough nicotine replacement, you'll soon learn it from the smoker. They're telling you, I need to smoke as well. You need to debunk the myth that they're going to overdose, because they don't, and they haven't, and they evidently haven't because they've done it before. So we strongly recommend they do combinations all the time. Interesting, there's no evidence to wean down doses either. So the 21, 14, 7 milligram nicotine patch regimen, there's never been any evidence for that. In fact, I know the man, because I have been in this area for a long time, who actually invented that regimen. And you don't have to do that. What happens with long-term use of patches, for example? I keep them on the 21 milligram dose. I've got an algorithm for this. You can access that easily because I've got some references at the end, how you would do this. You stay on nicotine patches 6 months, and then you can just stop wearing them. You don't have to go down. You don't have to be weaned off. There's no evidence for that. Debunk all these myths. No long-term abuse, as I mentioned earlier. So just reminding yourself again, which one should it be? Reminding you that NRT right now is not on the PBS. Some areas and some of your clients might be approved to get free NRT. Indigenous patients are, but by and large, most of our clients today are not able to get NRT, or unfortunately, especially not. Remember, we're using quite a lot of NRT in the beginning. This is only in the beginning. You can't overdose. You can use multiple forms. This is why I'm saying debunk some of these myths. The longer the better, and it's safe in pregnancy, in the whole perinatal period. This is just to show you plasma levels of some of our products. So this red line is a Nicorette patch. This is smoking. So this Nicorette 16 milligram patch isn't really going to cut it for somebody whose plasma levels in nanograms. Remember, all this is nanograms per mil, not milligrams. So you're getting a milligram patch, but your plasma level is in nanograms. But even so, it's very effective, but for a smoker. But look at the levels, they're so much lower. That's why we add one thing on top of another to pull up the level, to make nicotine replacement therapy replace it. And now we know vapes are right up here. I'll show you in a second. Right, really high, and remember it decays. This is 2 hours later. The slow release of nicotine from patches is why we put patches on just before you go to sleep at night, not in the morning when you wake up. If you have a smoker who says, I need to smoke on waking, put a patch just before they go to sleep, and they'll get a reasonable level of nicotine from that patch when they wake up. It changes everything, and it changes their time to first cigarette. This is just to show you that sort of speed of delivery I mentioned earlier and why that matters. So no patch addict on the planet. Yes, there are some gum addictions to lozenges, addictions to the oral spray. The faster it delivers nicotine, the more dependence producing it is, the more neurological and the more vascular effects. So is the patch safe in cardiac patients? Absolutely. No problem whatsoever. Are they addictive? No. What about electronic cigarettes? Cardiovascular effects? Yes. Vascular effects, right? Neurological? Yes, absolutely, because they're very fast deliverers of nicotine. So this is just a reminder of how we combine. We apply in the morning. We assess the topography. I do anyway, but always measuring carbon monoxide. You can do things like recommend a gum, a nicotine-containing gum, and a cigarette in that order, not the other way around. You feel like a cigarette, have a gum first. Then when you smoke, you don't inhale as deeper. So that's a really good way to start preloading. This is called preloading your patient with the idea that some nicotine, I won't need to smoke as much, or they may or may not know that. And you can just continue to smoke for a while and then add some more. That's the little art of this. That's the benefit of using NRT and smoking, and it's a gateway to quitting. That's what it relieves the cravings, it helps them with a bit more autonomy, and it motivates them to quit without you having to say you need to quit. So that's my language with my patients. This is TGA approved strategies, cutting down to quit, if you haven't heard of this before. What about vaping? Quickly to tell you, the amount of nicotine or the bioavailability from vapes is due to the level or the amount in the actual apparatus itself. And you've probably seen these different types. What they say on it, how many puffs there is in it, doesn't necessarily resemble what is in your plasma. Remember, 3,000 puffs, people say, oh, well, that's, 50 packets of cigarettes. Well, it's, the content of this might be high, but that doesn't mean you get all the content. It depends on a whole lot of things, and one of them is the hardware. And nasty people who make these things put very small batteries in there. These like batteries for some very small ear apparati, for example, with very small batteries, the battery runs out before the content runs out. So people think they've used up 3,000 puffs in a day, which is a lot. Are you really 3,000 of the? Not really, not usually. Do the maths and that's a lot. And what's happened is the batteries run out and you've got to have to buy one and a new one, and that's part of the consumerism that's unfortunately driven by the nefarious people who sell these things. The advantages over smoking cigarettes is obviously there's no combustion, there's no carboxyhemoglobin, there's no hemo concentration. So that is correct. There's no tar because there's none of that yellow, not going to stain your fingers, there's none of that yellow tar in it. But now we're looking, there used to be no particulate matter in it. They always claimed this, but now there might be micro particulate matter, especially the flavorings. The motive to use them was because it was so much cheaper. And now I'd like to ask you, do you know how much a packet of cigarettes costs? Anybody in the room know how much a packet of, say, Benson and Hedges, still the most popular brand, strong Benson and Hedges. Does anybody in the room, anybody want to quickly volunteer how much is a packet of cigarettes in the supermarket if you went into your major brand supermarket? Do you know how much it is? I can't actually see anybody's responses. Does anybody volunteer?
No responses there. No responses.
There are none.
There are no responses.
No responses. Right. So just so you know, $73 for 25 in a packet of Benson and Hedges. It's $73. Check it out. Go to the checkout of your ordinary supermarket. Now, if you live remotely, it's even higher. That is away from the major cities. Anybody have an idea how much a vape might cost in the room? It's worth your while finding this out. $70. Imagine if you do a packet a day. You're doing your whole pension on this. And that's true. So people's motives to use vapes was because it was cheaper. Now, because of the new and changed regulations, of course, it makes access to vapes very difficult. Out there in the market, it's like buying any other illegal product now. So they're becoming the same price as cigarettes. The potential, of course, is to reduce heart disease, reduce lung disease, and reduce cancers. That is what people have been saying, potentially. However, we're now seeing the risks, of course, of these shots of nicotine increases your blood pressure. And remember, when you're taking blood pressure and somebody's blood pressure is all over the shop, do they vape? Do they smoke? And have they just done it outside? Remember, it decays with nicotine, which has got a short half-life, so their blood pressure might be all over the place. If it is, find out. In my case, Renee, who's no history of smoking or vaping, if I smoked a cigarette, up would go my blood pressure and it would decay with nicotine. So it causes this significant vasoconstriction. Remember that, you probably learned that once upon a time years ago, that's what nicotine does. It also, by the way, raises your blood sugar. If you have people with blood sugar all over the place, it also decays with nicotine. Interesting. So watch this space for all, at least watch out on your patients if you're taking their blood sugar, and it's all over the place. So in the lungs, of course, the lungs it's not like smoking. There's no carbon monoxide, as we saw, but there are pneumonias and flavorings, and they are looking like they're significant cytotoxicity on the lining of the lung from the flavorings in particular. But now there's other little concerns about other products in vapes that we don't always know about and need to find out more. Obviously, the brain and the addiction nature of this, addictive nature, and the long-term effects of brain development, and the short-term effects on the brain in mental health the oral effects I mentioned earlier, passive vaping I've mentioned. And of course, the other thing about these products, that they might look nice and plastic and pretty or whatever. There's no quality control over any of this. No, none. People think, oh, well, you know, it's safer, but how on earth do you know what's in it? You know, unless you're a chemist and looking at this, people want to. Now it's too expensive to do either. We've got kids. I've got kids coming to see me because they can't do either of them. They can't buy it. They were doing fairly unpleasant things to have to get the money to buy vapes, but now that's just become impossible. Kids are certainly being under huge pressure at the moment to quit. The motive, the social pressure is significant, and those legal and prescription pressures are huge, and the medical effects in some are driving people, including kids, to quit. Just about the mental health effects, I'm again an overview of how important and impressive it is when you're helping people quit nicotine, and the impact it has on their mental health and substance use disorders and the substances that they're concomitantly using. It's hugely positive. It's not a negative outcome. It's a hugely positive outcome. The potential to become addicted to vapes is really significant. There is no exit strategy. What's interesting about PBS, there's no PBS subsidy likely with vaping. I might add that, and you need to add that to if you're going to recommend vaping. And I have developed an algorithm you won't see tonight, but I'm happy to share it when I can, on at what point would you default to vaping? At what point do you say this patient is just not going to get enough nicotine? They're not going to do well in any other. At what point do we decide, okay, it's time that we either initiate vaping or continue to vape because they can't stop vaping? I think it's our obligation to say something about an exit strategy, because you're likely, and it's our responsibility to say this, that the risk of staying on vapes is pretty indefinite, pretty permanent. The exit strategy is incredibly difficult. And for those who know this about young kids, we're now seeing some kids taking up smoking because they can't get vapes, and they'll send somebody into the supermarket, share the cost, and divvy up the cigarettes. What about harm reduction or minimisation? I'm for what's called, and we're signatures to this, precautionary principle. I mean, the signatures within the WHO, I'm sure you know this, and not just the WHO, it's also included in the UN charters that we've signed. Precaution as in, if we don't know, we do no harm, of course, and we don't know, so we take precaution. Is it the same for vaping as it is for smoking? There are very varying differences. As I talked about, the variety of people doing varying things. But the most important and impressive difference for me between vaping and smoking is the fast delivery of a very high dose of nicotine. So the dependence liability is huge from vaping. I'm very nervous of what's going to happen to some of our adolescents who are into this. How do we help adults quit vaping? Obviously, informing education. We have a vaping dependence questionnaire, which is very much to what we've talked about. I've shown you a little bit about what you can do. Time to first vape is for me a major marker, a major question to ask. Time to first vape, time to first cigarette. Treat nicotine withdrawals, use pharmacotherapies, use high doses. Do we wean them off the content in the vape? There's no evidence for that, though some of the prescribed vapes now, they're calling therapeutic vapes that are prescribed through pharmacy or dispensed through pharmacy, wean people off. However, there is no evidence for that. None, no evidence. Mind you, there's no evidence that vaping itself is better than smoking, or actually increases cessation all up. That's why the TGA is very equivocates on this significantly. And I use these biomarkers as, if you could, that would be great. Just a few words about behavioural interventions before I stop and go on to cases. This is a little bit about what can you say about smoking that is valid and evidence-based. The very first, for starters, is menthol vapes. People don't know this, but mentholated anything, including cigarettes, and some of you may know, we used to have cigarettes called Cool with a capital K, which were pitched at women. Mentholated cigarettes, or mentholated vapes. Menthol itself induces, of all things, induces nicotine acetylcholine receptors in the brain. Strange quirk, but we would never recommend mentholated cigarettes and not vapes either, though there are arguments. I'm distinctly opposed to mentholated vapes. People saying, well, that it helps people convert to them. Do we want that? Do you put up no vaping, smoking here signs? Is it valid? Is it sounds a bit excessive? No, it actually helps. So cues, as in CUE, cue conditioning, responses to these no vaping, smoking signs here. We've done this, the studies that show that it actually helps you remember to not do it. So just as you've got environments where the cues are there for you to do it, we have on cues and we have off cues. And people have learned to not smoke in the bus, to not smoke in their bedroom. They've learned this and they don't even know they've learned it. So we're talking about turning off cues. You'll see in a moment. You learn how to behave in the circumstances that you're in your normal environment, but turn off the cues. I like to turn off cues by always, if you're going to smoke or you're going to vape, so you're wearing a patch for the first time ever, and I've told you you can smoke, but if you're going to do that, you do it outside. Everybody does everything outside, even if you're by yourself. It's not hanging out the window, or I'm in my car and nobody else is there. You get out of the car to smoke. Now, this is all evidence-based. You've got copies of all this, so you're welcome to use these things. This is some more acute tips, and I don't think I've got much time, I think, at all left. So I'd like to just perhaps talk a little bit about, some other things that you could do. I've talked about no smoking signs and what else you could do to help with urges to smoke. And I'd like to now, do I stop, Monica, for case studies, or would
Yeah,
that need to be?
we can continue with case studies. I mean,
All right. So I'm just going to put up a case of a, and then we might just stop for some questions about this case, right? So these are real people. So this is a man who was absolutely not interested in quitting. I don't want to do this. I'm not interested. I'm coming here he came to see me absolutely reluctant to do this because he had an acute exacerbation of his COPD. He started very young. He woke up and did it, opening his eyes, rolling cigarettes. He had a past history of substance abuse. He had never tried to quit, not interested. His doctor gave him a patch, and he said, "No, look, I'm not interested because I smoked anyway. So I tried it for a day, and I smoked anyway. So it doesn't work. These things don't, it doesn't work." And his GP was not interested in recommending even take something like varenicline due to the mental health concerns. So he came to see me, and I tested his carbon monoxide. So I did that breath test. And he read 3 parts per million, which is not really, remember I said I had one about 100. So he's not hugely high. I did his salivary cotinine of 800 nanograms per mil, which is, highish. And I started him out on a patch at night with instructions to continue to smoke. So I said, Michael, look, honestly, let's try to manage this better. You're making everybody around you upset. If you put a patch on and smoke anyway, can you just do that every day and see what happens? Oh, I'll smoke. I said, that's fine. That's fine. So we did that remember that carbon monoxide test. He comes back a week later. He's smoking half the amount he normally smokes per day. And his carbon monoxide expired, so breath in the test is 16. And he hasn't had to do anything. He hasn't had to quit, to cut down. I haven't told him anything. You want to smoke? Fine. The one thing I have said, go outside to do this. Oh, okay, I'll do that. But that's it. So it's not rocket science. He comes back, it's 16 parts per million. I add a second patch. When he puts 2 patches on, he comes back a week later, 2 patches, it's 4 parts per million, and he hasn't even had an urge to smoke. And I haven't said to him, stop smoking. He's just not interested. All it took was 2 instead of 1. Then he remains now many, many weeks on, off. I've gone down to back to 1 patch after 2 weeks, 2 weeks of 2 patches. So this is how I would do it: a patch at night and a second one in the morning. And he did that for 2 weeks. He's abstained more than 12 weeks now. And to get him off the patches is simple. 21 milligram, no cutting down strengths of patches because it's not required. You can go 1 day off, 1 day on, and then stop wearing them. And that is the end of that. So that was the only thing it needed, which is very sad to hear, was a second patch. He's surprised, everybody's surprised. So I might just like to, would anybody like to talk about that case? I'm not sure if you can see me. What do I do now? I go to stop sharing. Do I do that?
Yeah, you can stop sharing. Yeah.
Would that be ideal? And we'll go to the chat. Does anybody want to talk about somebody suggesting $25 for something? Was that for cigarettes? Yes, Michael totally stopped. Totally stopped. And that's been our strategy for many, many cases. And that's all it took. And it's because it's not recommended by the pharmaceutical companies that make them. However, there's many, many papers on this, right? This is called combination therapy. You can add a second patch, you can add gum, you can add things, and they all totally stop. And you haven't had to say, well, I mentioned the follow-up. Yeah, I'm doing follow-ups all the time. 12 months later, I always follow up. I always do biomarkers because reporting self-report, it's not that I don't trust you, but I don't trust you. And no, I do trust people, but follow-up, you saw, always proves a negative cotinine and a negative are the nicotine? No, they don't cause. The insomnia is really interesting. The question about insomnia is really interesting. So if you put a patch on in the morning, it peaks at night, and that causes insomnia. If you put the patch on just before you go to sleep at night, you wake up in the morning with a viable nicotine, and it doesn't cause insomnia. It's the opposite. So the insomnia is invariably due to putting the patch on in the morning. And remember, some of the people put it on, or they've had breakfast and they get up, and then they put it on. So it's peaking just as they go to sleep. Bad timing. The instructions about when you put on these nicotine patches have never been any good, and they're still not very good. But it doesn't say when to put it on. Don't put it on in the middle of the day is a really good thing to say to you. Don't pop, because it may not say at all in the instructions in the box. And pharmacists, of course, are rigid on the patient information, and we are not. This is absolutely standard procedure for myself and my colleagues, nicotine addiction specialists like myself. We would do this standard. And there was the question about weight gain that I do want to address if I could. Now, this particular chap, and I didn't put it in here, but I thought I'd mention it. None of the patches are covered on PBS, Ethan, but it's only for 2 weeks. And remember how many less cigarettes they're already buying. I just wanted to, I would recommend, if you're going to do this, it doesn't require a lot of this for a long time. But just back to the weight gain of this particular gentleman, he was really cahectic. He was really underweight. And typically, nicotine suppresses appetite. So keep that in mind. Nicotine has this sort of appetite suppressant effect. It's the serotonin that does this. But there's another effect. I'm just curious in the audience, has anybody had a patient who, when they quit smoking, put on a significant amount of weight? Anybody? A significant, I mean, many, many kilos in a short period of time. What we've seen and published case reports on is that people, unfortunately, who are prone to this, and it's usually people with thyroid, a family history of thyroid toxicosis, Hashimoto's, unfortunate family histories, may put on. Nicotine is incredibly toxic to the thyroid. And we've been able to show, if you have a smoker who's done this in the past, who's put on a significant amount of weight when they stop smoking, check their thyroid stimulating hormone pre and post cessation, and just check it out, because we've seen it significant, huge rises in thyroid stimulating hormone in some people. If you give them enough NRT, that will not happen, which is interesting and important. And that's a little bit about weight gain. What about, I mentioned blood sugar. Nicotine raises your blood sugar. So smokers often, and vapers now too, often like something sweet after a meal. You and I like something sweet after a meal. I'm always looking for something sweet. Smokers have a cigarette to raise their blood sugar. And unfortunately, you need to, and we've got this in the recommendations, is to use something like glucose or something sweet if you have an urge to smoke. No specific test to prescribe or recommend nicotine patches, except that it's not necessarily contraindicated in anything at all. There's no test at all. As I said, it'd be great if you could do that carbon monoxide test, but time to first cigarette or time to first vape changes when you're giving them enough nicotine. So if you're putting on a patch at night, like Michael, and I don't have time to nuance all of this, you put a nicotine patch on. When he wakes up in the morning, the urge to smoke is not as great as it used to be. So time to first cigarette is a test, if you like, or a marker of the patches working. As varenicline, it's the same. Champix, it's the same. If Champix works, when they open their eyes in the morning, the urgency to do it isn't as great, even though they're still doing it. And that gives you a hint that it's working. And just keep adding, keep adding. You're not going to overdose them. There's no negative side effects of these things at all. It's just understanding it better now. Hopefully you're all understanding this a little bit better. Can I maybe show you the next case?
There's a question in Q&A as well. It's not a question, but then yeah.
Oh, sorry.
From Stephen Wu. He says, from my personal experience, I find little interest in pharmacological methods of smoking cessation. When I meet patients who want to quit, they always say they will do it alone without pharmacological drugs. Not sure if people who are addicted to nicotine or smoking have a certain personality that make them prone to addiction and also resistance to treatment with NRT, etc.
Well, usually, first of all, there's no evidence that it's a personality trait at all, none. As I said, we've got lots of the genetic studies, we've done lots and lots on that. There's no evidence for that. People resistant to taking pharmacotherapies are possibly people who've tried it before and have done very poorly. So that's why I've suggested some of the barriers are those things. So, as I said, if you could, and if you manage this, talk to them about managing this better to do less harm, for example, is a way you can address this. They say that they can quit cold turkey, but the proof of the pudding is in the outcome. Can they, and have they? Yeah, some people would like to do that, but have they been able to achieve it? That's I guess the show me that you can do that. Then that's really my response to that. It's certainly not a personality and trait that we have any evidence for us at all. But I'd like to suggest to them, if you're not doing well, and not to say you've failed, but if you're not doing well, can I suggest you try this for, even for a day, and remember, we've got evidence to support this. You could try this for a day, put on a patch for the day, see what happens. Is there any difference from you trying to do it without and just doing it for the day? Just in the morning, not overnight thing, but in the morning, and go for the day and see what happens. We've done that in our big campaigns, like in the supermarket or in the big malls, the shopping malls, or during Easter, the big show days. We've gone out to big conventions and places where there are a lot of people, the Royal Easter Show, for example, in Sydney, and put patches on in people who come through the turnstile and come back and see us on the way out. And we do their breath test going in and their breath test coming out. And guess what? It goes down. And they're still smoking, wearing a patch. So that's a little bit of a way we just entice people to think about what they could do to smoke less, and then go from there. Apart from everything else, it saves them a lot of money.
I think we'll go to the next case because there are no more questions.
Okay, sure. I'll just share this. This case is a person I'll just go. This is Hannah. She's a never smoker, had no other substance use, and commenced vaping. So she's 44. This is not somebody who's ever smoked, had no interest in it. And somebody suggested that she has a go at this because she's got a very stressful job. She said, I'm a lawyer and I'm busy, and she's a mum and she's busy. And she's absolutely humiliated by this. She cannot stop. She's had multiple attempts to quit, highly dependent on nicotine, does it everywhere. And so I just did exactly what I've been doing. We've got no carbon monoxide test to use as a biomarker to show her a reduction, because those reductions in Michael, you show him this biomarker, they're so chuffed. People love this, to see the change. It's like getting on a scale and seeing you drop weight. It's just so encouraging. But we don't have much in the way of doing tests. But because in her case, I can't use my biomarker from my little test that I've developed. We can't use that because it will come up positive because she's on NRT. but she is absolutely stoked that she doesn't vape now. You know, vaping outside, start off with one form of NRT, add another, and that's it. So I'm just giving you a demonstration of somebody who was never a smoker, no history of smoking. If you thought that, well, that's inevitable, she's going to be vaping for the rest of her life, yeah, that's not true. It just isn't true. And I think it's just an example. And I'd be interested if anybody else has got any views on this one, this case, in the chat. Or have you yourself seen people vaping? Anybody coming to see you to quit vaping?
There's a question in Q&A.
Yeah.
Are you able to see it?
I can see it. If one patch at night is not enough, what is instructions for the second patch? Remove the night. No. You're overlapping. So one at night and one in the morning. You're wearing them two at a time over the day. Now replace the one in the morning and switch at night to the next one. Do they accept? There's no insomnia. Don't go down this insomnia thing. Any other practical tips? Well, as I said, we could be going 3 patches at a time, and I do that, and it's, again, well documented if you care to read about it, in the literature, I mean, in the academic literature. And what we would do is one at night, one in the morning. So when the morning one peaks, the one at night is dropping. And you just have to remember, and sometimes I get them to mark it with a pen, which one's your night patch, which one's the morning. If a third one is added, I add it only for the daytime. So you might have 2 in the morning being put on top of the third one, which was at night. And as I said, there's no insomnia concerns. Insomnia, by the way, is also a symptom of nicotine withdrawal. And the other thing about insomnia, if I haven't mentioned it or you didn't notice it, is caffeine levels. So always remember they've got no PAHs because they're now on NRT. So if you have a smoker who says, I'm wearing a patch and I can't sleep at night, how much coffee are you drinking? And they'll tell you, the same as before. 5 cappuccinos every day and 2 liters of Coca-Cola. No wonder they can't sleep at night. Remember, they are drinking more caffeinated drinks because they're smoking, and it's the PAHs that are inducing that, not nicotine, has pushed down those caffeine levels. Now they're not smoking anymore, up go their caffeine levels. So always inquire, if they say insomnia, how much caffeinated drinks are you using? And tone it down. You don't have to stop coffee. What about nightmares from varenicline? Any tips dealing with this side effect? I think, again, the nightmares with varenicline needs to be taken 8 hours apart, as in on waking with food, and 8 hours later, not a lot later, not just before you go to bed. And that's a tip for nightmares with varenicline. Remember, these all are chemicals that are acting like either as an agonist or an antagonist to nicotine. They're either nicotine itself or an antagonist, as in varenicline, which is an agonist and antagonist. So it's doing both. These are stimulating nicotine acetylcholine receptors. And we don't usually, obviously, we don't smoke at night, but is this a bit of a stimulant at night and causing nightmares? So if you can, the second tablet is taken earlier. Don't take it just before you go to bed. Take it with dinner. Take it with food, by the way, never on an empty stomach. So I hope that's helped with dealing with the side effect of nightmares. And by the way, varenicline is interesting in terms of nausea. If you have patients who are nauseous with it, it's usually a weight relationship. Efficacy is weight related. We're now seeing papers with bigger people having higher doses and smaller people, little women, taking half a tablet instead of a whole one, and it's still being efficacious. Counseling young people to quit vaping has become very difficult for all of us because, of course, it's the how you counsel young people is information enough? Is telling them they're being manipulated? Currently, there's a lot of work you've probably heard about going around at schools now with peer support, young kids that have done it themselves, talking to other kids about how to quit vaping, how to manage withdrawals. Do they always have withdrawals? Do most of these kids need pharmacotherapies? We don't know what the natural history is of helping them quit and getting them off it. But everybody's doing their darndest to make it uninteresting for them, talk about being manipulated, like those, for example, the batteries run out, so you've got to get another one. That's intentional that the batteries are running out. So you sort of talk the talk about being manipulated, all the flavorings being there to entice you so that you become a vapor for the rest of your life. Is that what you want? And depends on, again, the age. Everybody's doing the best they can at school. We hope that parents are hopefully understanding of what addictions are like in young kids and how they can be a pretty unpleasant kids for a short period of time. We hope that schools are managing this better than some schools. I'm currently seeing a young man who has been expelled from school. 3 strikes, you're out. Caught vaping in the class under his t-shirt, right? Literally under his t-shirt like that. 3 strikes, you're out. Now, I don't think that's an appropriate thing to expel. I think we should be able to manage it better and have a better understanding and better education around vaping. And as I said, peer group support looks like the way. There's another way that's been very interesting. It's called contingency management, which I haven't really talked about, but it's certainly been used in pregnancy, in pregnant women who smoke or vape, and in kids now. It's not exactly that you pay them, but you reward them for not doing it. You validate their abstinence and you reward them. So it's been done in pregnancy a lot now, saying if you blow 0 or very low readings in your carbon monoxide test or in your cotinine test, we will reward you with vouchers, or in pregnancy in things for the baby. Every time you come, your whole your postnatal and perinatal and assessments, every time you come, you get a gift. Every time. So this is in order to maintain abstinence, and for the rest, in kids now, they're doing the same. It's not exactly pay them to quit, but it's called contingency management and giving them rewards. Very helpful. No money, of course, no money. So I think I'm 9:30 in my, it's 9 o'clock in your town and it's 9:30 in mine. Andrew, I think you had something to help finish off the evening with.
Are you there, Andrew?
Yes, sorry. Yes, thank you so much, Renee. It's been such an insightful and amazing presentation. It's always wonderful to hear you speak, and sharing those examples, I think, is just obviously struck a nerve with everybody. And I think it's been wonderful to see the questions and people's interest, and we're really keen to see this, I guess, keep going, and the opportunity that people have to join the audit project that I'll be facilitating with SAPMEA. So essentially, I guess, good practice is to undertake the 5As and consider RACGP guidelines in approaches as well. So we'll have the opportunity to undertake an audit, or people will have an opportunity to undertake audits of themselves and what they're doing. And and look at things like, are they actually asking the question full stop around smoking or vaping, and then developing into all those, I guess, interventions and points that you discussed today in your presentation, Renee. So I think the audit will also consider things like referrals to the quit line, how they might be appropriate for dealing with clients in providing support where you might be unable to, or also for that opportunity in improving quit rates, and talking about things like combination therapy as well, and continuing a consideration of your own practice and your own goals in terms of what you might look to achieve in what you're doing in your practice around smoking cessation or vaping cessation. So I think it's going to be a really exciting opportunity to really keep these conversations going and share experiences with one another. And I'll be really I guess keen to support those conversations and keep things coming along in how you're perceiving your own abilities to talk about smoking and vaping cessation, but then also